Alright, so today I'll be talking about this topic, liver in tropical fever and protozoal disease. So this talk I gave in Vizag South Zone Criticare that happened on 17th August 2019. Okay. So the topics I'll be covering is just a background about how liver gets affected in tropical disease, bit about Leptospira, how it affects liver, dengue virus, the way it affects liver, malaria, typhoid, amoebic liver abscess, and take home message. So when you look at liver in tropical disease, so why does liver get affected? So basically, it can be affected directly by the organism infecting the liver, or by the endotoxins or other toxins that organisms produces within the liver. So and these endotoxins can be endotoxin, it can be thromboxane B2 or leukotriene. So these are some of the endotoxins or cytokines that are produced which can affect the liver. And liver can also be affected due to the hemolysis and fall in the hemoglobin that happens. And it can happen due to dehydration, or it can happen due to hypoxemia also within the liver. Okay? And there can be hemolysis which can affect the liver. So when you look at leptospira, so this topic will only confine to the liver aspect of the disease. So I won't be talking about the other system, because although leptospira would affect multiple other organs, so leptospira basically infects the human being either by inhalation, ingestion, or by entry into the skin bruises. So if there is any bruises or skin lacerations, it can enter through that. So that may be the portal of entry of leptospira. So the main pathophysiological aspect of leptospira is it causes severe vasculitis. And this vasculitis can affect the brain, can affect the heart, can affect the liver and the kidney. So multiple organs that get affected in leptospira is attributed to the intense vasculitis that happens, which can affect these organs. So when you look at leptospira, there are two major clinical presentations. You have an icteric leptospira and anecteric. Anecteric is a benign form, so it is a self-limiting. It is a benign sort of a disease, so which may not be life-threatening. Icteric form is more dangerous. That can lead to multi-organ failure. And we call something as Wheals disease, where there is multi-organ failure along with bleeding manifestations. If someone has multi-organ failure with a lot of bleeding manifestations, it's the severest form of leptospira, and we call it as a Wheals disease. So leptospira typically has three phases. So the first week is called the septic phase. The second week is called immune phase, where there is extensive immune activation leading to vasculitis. And third phase is the happens in the third week, which is a convalescent or recovery phase. So when you look at liver dysfunction in leptospirosis, so the studies from Brazil has shown that leptospira can directly infest and affect the liver, or there can be extensive immune complex deposition within the liver, which can affect the liver. And typically they can present with tender hepatomegaly or tender right hypochondrium. And the liver features biochemically would be there will be increase in total bilirubin, increase in direct bilirubin, increase in the serum alkaline phosphatase, and they can manifest with acalculous cholecystitis. So leptospira can have tenderness in the right hypochondrium and acalculous cholecystitis, and they typically have increased in AST, ALT, but rise in AST is generally mild. Okay. And there can be reduction in the albumin. And this was a study from Taiwan which showed that, as I said, AST ALT is milder, but there is more increase in the bilirubin. But this study from Taiwan indicates that if AST and ALT ratio is more than 3, because if AST rise is much higher than ALT, it had a direct correlation with increase in mortality. So that is one of the prognostic marker they have identified. And when you look at pathophysiological aspect or pathological changes that happen in the liver, so this is a hepatocyte. So there is a degeneration of the hepatocytes that happens, and there is central necrosis that happens within the hepatocytes, and there is deposition of these acidophilic bodies within the hepatocytes, and this is a portal tract which contains portal vein and artery, and you have a biliary tract. So they can have cholestasis and there can be portal inflammation. And this is a Kupffer cell, so they have Kupffer cell hyperplasia. So these are typical pathognomonic features that you would see in leptospira. So if you remember this picture, I think these changes within the hepatocytes, hepatic degeneration and and the necrosis of the liver cells. So these are common to all the infections that I'll be talking. So if you remember this figure, pretty much these are the microscopic changes that happen at the liver. And clinically, they present with jaundice, and generally they say the bilirubin will be less than 20 milligram per deciliter. And if you look at the clinical phase, 4 to 7 days, they have jaundice which peaks, and then it tends to plateau, and the jaundice may last up to 3 weeks, and it starts coming down in the third week, and it may last up to 6 weeks. So this is the typical progression of jaundice. And the jaundice can be more intensified or magnified if there is a concomitant presence of the acute kidney injury or renal failure, because your bilirubin excretion does not happen because of the concomitant presence of acute kidney injury. And hemolysis also can contribute to jaundice, but hemolysis is claimed to be less that leads to jaundice. So the contribution of hemolysis is found to be little less. And there can be coexisting thrombocytopenia also that can be present as a liver manifestation. And with regards to other clinical factors, they can have severe and throbbing headache. 80% of the patients are known to develop aseptic meningitis, which leads to altered sensorium in Leptospira. And the pathognomonic feature of Leptospira is meant to be conjunctival suffusion. So 30 to 99% of the patients will have red conjunctiva or conjunctival suffusion, and that is claimed to be one of the pathognomonic sign in Leptospira. GI symptoms, they can have vomiting, diarrhea, and severe abdominal pain, and they can have skin bruises or skin rashes in 2 to 30%. So the percentages, I think these are the references which have come from the US literature. So we'll move to the dengue virus. So that's about the liver affected by Leptospira. So dengue virus is a flavivirida. So there are 4 serotypes, and the 2.5 billion people globally are at risk for developing dengue. Annual incidence is 50 million. So when you look at the dengue virus, so this is typically a dengue virus. How does it affect the liver or in general? So dengue virus predominantly affects the blood vessels. So this is the endothelial cells within the blood vessel. So dengue virus does produce inflammatory mediators like tumor necrosis factor alpha, which leads to typically paracellular or intracellular leakage at the endothelial level. So this is the endothelial cells, and there is a loss of integrity of the endothelium, and there is a paracellular and intracellular leakage of fluid that happens. And dengue virus, why do they bleed? Because they cause reduction of this activated protein C, and because of the reduction of activated protein C, the bleeding manifestation can set in. And in dengue virus, there is this expression of these dendritic cells, and there is increase in the production of gelatinolytic matrix metalloproteinases. So basically, there is release of these sort of a cytokine called gelatinolytic matrix metalloproteinases, which are produced by these dendritic cells, and this is known to reduce this vascular endothelial cathedrin. This dumbbell-shaped protein, what you see, is called vascular endothelial cathedrin, which are bridges which maintain the integrity of the endothelial cells within the vessel wall. Because there is reduction of these vascular endothelial cathedrin, the integrity of this endothelium at the vascular endothelium is lost, and there is leakage of fluid from the blood vessels. That's why you would see your hematocrit is very high, because the blood loses lot of water content because of loss of this endothelial integrity. That's why you have leaky capillaries or leaky blood vessels, which leads to rise in the hematocrit in dengue. So this is the core essence of pathophysiology that happens at the vascular level. So dengue virus, like leptospirosis, can directly infect the liver, or because of the presence of dengue virus within the liver, there can be dysregulated immune response by the liver to the dengue virus. So the liver manifestation, there can be mild increase in AST-ALT to severe injury, where there can be profound rise in increase in AST-ALT, which can lead to fulminant hepatic failure in small percentage of patients with dengue. And it is claimed that 60 to 80% of the dengue infections have raised AST-ALT, which we see in our practice. We do see this predominantly most dengues will have abnormal AST-ALT. Increase in AST is more than increase in ALT. Like in lepto, AST will be more than ALT. But what they found is the AST normalizes before ALT. The reason is AST has a shorter half-life of 12.5 to 22 hours as opposed to ALT which has a half-life of 32 to 43. So although AST rises more than ALT, AST normalizes and ALT normalizes much later because of a longer half-life of ALT. And the liver rise in enzymes typically happens peaks to day 9 and lasts for few days and then normalizes by 2 to 3 weeks. So that is the progression of liver dysfunction. And like the picture you saw in leptospira, even dengue can directly affect the hepatocytes and antigenic expression can happen within the hepatocytes. They have identified dengue antigens within the hepatocytes. And like in lepto, you see those centrilobar necrosis and you have acidophilic bodies. As in leptospira, you see deposition of these acidophilic bodies within the hepatocytes, and there can be inflammation of this portal tract and Kupffer cell hyperplasia. So when you look at all these studies looking at the spectrum of enzyme dysfunction, 86 to 90, so these are around 8 studies from various authors, 86 to 96% of the dengue will have raised AST and 45 to 97% of the patients will have raised ALT. And as you see, hyperbilirubinemia may be an indicator of severe dengue. So only small percentage, 1.7 to 48% will have hyperbilirubinemia. And more than tenfold rise in AST-ALT, which is severe liver dysfunction, happens in small percentage, 1 to 11.1%. And what about liver failure in dengue? 0.31 to 4.44% of the dengue patients can have liver failure as per some of the studies. So it's a very small percentage which go into liver failure. It's a 0.31 to 4.44. And the mortality obviously when they have liver failure is very high. It can be anywhere from 20 to 100%. So this was a study by Brazil group Souza et al. Where they have staged severity of dengue based on the liver dysfunction. So grade A is where there is normal enzymes. Grade B is there is some increase in AST or ALT. Grade C is there is increase in aminotransferases more than 3 times. And grade T is there is increase in aminotransferases up to 10 times. Okay. So if you want to know the grading based on the liver enzymes, this is the grading. And this was a study by Pakistan by Prakash et al. Where they looked at the correlation of liver dysfunction to mortality. So they had 436 patients with mild to moderate hepatitis, 81 in severe hepatitis. But there was no difference in the mortality between these two groups. But ICU length of stay was longer in patients with severe hepatitis in this study. This is in patients present with dengue fever. Then they have taken dengue hemorrhagic fever or dengue shock syndrome. They had 60 patients with mild to moderate hepatitis and 22 with severe hepatitis, and they found the death was more where there was severe hepatitis that was statistically significant. But ICU length of stay, there was no difference. Basically, from this study, you can conclude that liver being affected may be an important prognostic marker for longer stay in ICU or for high mortality, more so when they present with dengue hemorrhagic fever or dengue shock syndrome. So we need to be worried. If liver is severely affected, it does have a bearing on mortality and length of stay. So clinical features, you have 3 types of dengue: mild dengue fever, dengue hemorrhagic fever and dengue shock syndrome. And as I mentioned, AST-ALT rise is more common in dengue, bilirubin rise is less common, and presence of jaundice may be a poor prognostic sign in dengue, and presence of jaundice may have a good correlation with dengue shock syndrome, non-survival or bleeding manifestation. So if you have a patient with dengue presenting with jaundice, so it is an alarming sign. It may lead to non-survival or it may lead to bleeding manifestation. And there can be imbalance between the coagulopathy and the fibrinolytic mechanism, which may lead to bleeding manifestations. And this was a study from Indian group where they showed 17.6 to 20.4% of the patients can have hepatomegaly and can have tender hepatomegaly. So you can have tenderness because of this. So for the trainees, if you want to know, 20% of the dengue can have tender hepatomegaly. And this is a typical WHO staging of the dengue disease. So you have the initial stage which is up to 3 days, where you have temperature rise, and here you start developing dehydration, and hematocrit starts coming down in the first 3 days, and you are highly serologic. Your viremia happens at this stage. There is intense viral replication at this stage, where your IgM may start coming positive. From day 4 to 6, they can develop, fever comes down, and that is when they manifest with more alarming signs like shock, hypotension, bleeding manifestations, or organ impairment sets in 4 to 6 days. And here hematocrit starts rising. And then you have this IgM and IgG titers going up. Okay. Then you have this phase 3, which starts from around day 6, where there is no fever, and here you have more serositis. You have more of fluid overload picture. Platelets start increasing in this stage, and here the titers are at the maximum in this stage, in the stage 3 or phase 3, starting from day 6. So this is a typical WHO staging of the dengue, and I'm sure even in our practice we do see this manifestation, but there may be some overlap between these 3 stages in some of the patients. So that's about dengue and the liver. So we'll move to malaria. So malaria, this is a malaria parasite. Annual incidence is around 500 million, and there are 3 million deaths per year happening globally due to malaria. So liver, how does it affect it? Mild LFT derangement to, it can lead to fulminant hepatic failure in malaria. And malaria typically causes something called malaria hepatitis, where there is increase in bilirubin. You saw in lepto and dengue there is more AST rise. Here you will see more ALT rise. Okay, so there is ALT rise more than 3 times, and there is increase in LDH also. And presence of these three has a correlation with poor prognosis and multi-organ failure. So liver getting affected in malaria does have a bearing with mortality and organ failure. And presence of coagulopathy in malaria has a good correlation with the severity of the disease. And why does multi-organ failure happen? See, this is a malaria infected red blood cells. So once the red blood cells gets infected with malaria, so they express sticky areas. Okay, and these sticky areas gets adherent to the vascular endothelium, and these sticky areas makes all the red cells to clump with each other. Because there is intense clumping of red blood cells because of the infected blood cells with malaria, they become very sticky. There is clumping. There is an occlusion of the microcirculation or the microvasculature. Because there is occlusion of the microvasculature, there is anoxemia or hypoxemia. There is no adequate blood flow to the organs, which leads to anoxemia and cell failure or cell dysfunction and multi-organ dysfunction. So basically it is due to the clumping of the red blood cells, which become sticky as they get infected with malaria parasite. And like in other figures, I think this figure, if you remember, you pretty much know the pathognomonic features that happen within the cell. So like in other leptospira and dengue, there is a necrosis. So typically in all these liver dysfunction with tropical diseases, you have necrosis within the hepatocytes. You saw acidophilic bodies getting deposited. Here you see malaria pigment deposition within the hepatocyte. There is Kupffer cell hyperplasia, and there is hemorrhagic spots within the hepatocytes. And like in other conditions, you have cholestasis and there is intense portal inflammation. So this remains pretty much common with few additions and deletions. Okay. And clinical features, jaundice is a pathognomonic feature, and it happens in 11 to 62% of patients with malaria. And this jaundice is mainly due to DIC and hemolysis, intravascular or microangiopathic hemolysis that happens. And this jaundice starts reducing within 72 hours after initiating the treatment. 60% of the patients are claimed to be having hepatosplenomegaly. So it's reference to have heptos. So 60% predominant number of patients have hepatosplenomegaly. So that's pretty much about malaria. So we'll move to the typhoid. So this typhoid, as we all know, is caused by Salmonella typhi. And in typhoid, the liver, there is something called balloon degeneration of hepatocytes. And like in dengue, you have this Salmonella typhi present within the hepatocytes, and there is lot of immune complex deposition within the hepatocytes. Like you saw in Leptospira, immune complex deposition. Here also there is intense immune complex deposition within the hepatocyte. And what you typically see in typhoid is all these Kupffer cells hyperplasia, they all get together to form something called typhoid nodules. And this is the pathognomonic sign of typhoid. All the Kupffer cells get clumped together and they form something called typhoid nodules. And like in Leptospira, you have arthritis within the liver, which can also lead to a lot of inflammation within the liver. And there is intense portal hyper inflammation. So, like in other conditions, the portal inflammation is a lot more intense in typhoid. And all these changes, so the coagulopathy that sets in can be mediated by endotoxin, and there can be complement consumption. So even in typhoid, if the liver gets affected, it is very much an autoimmune process. If there is arthritis, there is intense portal inflammation, and there is complement mediated inflammation and endotoxin mediated coagulopathy that happens in typhoid. And clinical features, 10% of the typhoid fever can have jaundice, and 50% of the jaundice is attributed to increase in the AST-ALT. This is from the Indian literature. And hepatomegaly is present in around 30% of the patients. In malaria, you saw 60%. In typhoid, 30% of the times they can have hepatomegaly. And hepatomegaly starts in the first week and lasts up to 3 to 4 weeks. And there can be tender right hypochondrium, and increase in the AST-ALT happens in 24 to 87, and increase in bilirubin happens in around 23% of the patients. In typhoid, another thing for all of us to remember is they can have microabscess formation within the liver, and there can be cholangitis and there can be acalculous cholecystitis that can happen in typhoid. And 10% of the jaundice the jaundice can also be due to hemolysis, especially when there is a concomitant G6PD deficiency or thalassemia. So hemolysis can be compounded when there is associated G6PD or thalassemia in typhoid. And typhoid hepatitis, I think one of the distinguishing feature is because we could often confuse this with other normal viral hepatitis. So they have looked at ALT by LDH ratio as one of the feature which is unique to typhoid. If ALT by ALDH is less than 4, it favors typhoid hepatitis. But if ALT by LDH is more than 5, it favors viral hepatitis. So this is one of the distinguishing factor between viral hepatitis and typhoid hepatitis. Okay, and hepatic dysfunction causing hepatic encephalopathy is rare in typhoid fever. Okay, and even to an extent, they say the triad of jaundice, high fever, tender hepatomegaly should raise the suspicion of typhoid fever in a clinician. So this is what is referenced in literature. But in intensive care, I'm sure we may need more than this to identify, because this may be hard for us to ascertain in ICU. So coming to the last tropical disease, amoebic liver abscess. So this is Entamoebica histolytica. 3 to 9% of amoebiasis can lead to amoebic liver abscess, and mortality is 2 to 15%. And it is predominantly found to affect young males, 20 to 45 years of age. And the pathognomonic feature of amoebic liver abscess is you will see abscess present predominantly in the right lobe of the liver in 30 to 70% of the patients. 80% of the patients will have hepatomegaly, and multiple abscesses may be present in 15% of the patients. And presence of amoebic liver abscess on the left lobe of the liver constitutes around 35%. Predominantly it's present in the right lobe. 35% of the patients can have it on the left lobe. And symptoms may last for up to 3 to 4 weeks. And increase in the transaminases up to 3 times can happen in 35% of the patients with amoebic liver abscess. Increase in alkaline phosphatase can happen in 60 to 80% of the patients with amoebic liver abscess. And increase in bilirubin can happen in 6 to 29% of the patients with hepatomegaly. So for trainees, if you want to remember these percentages, these are all referenced from our Indian literature. So you can, but predominantly what you have to remember is abscesses are more on the right side. Left side around 35% can have abscesses. Hepatomegaly is present in more than 80% of the patients. I think if you remember that, that should be enough. And it predominantly affects the younger male patients and more so in alcoholics. Okay? And they can have tender hepatomegaly because of this. I think another important thing for the listeners to keep in mind is the typical feature in amoebic liver abscess is they can have hemophilia. Why does that happen? So trainees should know the hemophilia happens due to the connections that happen between the biliary tract and the artery. So whenever there is an anastomosis that happens between the biliary tract and an artery, hemophilia happens. When there is an anastomosis or connections happening between the biliary tract and the venous circulation, you have something called bilhemia. So hemophilia and bulimia are some of the prognostic markers and indicate severity of the condition, where you have anastomosis happening between the portal tract, the venous and arterial circulation. And other features in amoebic liver abscesses, they can have encephalopathy. 33% can have jaundice, 10% will have pleural effusion, predominantly on the right side, because the liver that is there on the right side, and 4% can have ascites. So all these come from our Indian literature. So the take-home message is liver is affected in most tropical infections, and common infections in our country are dengue, which we have covered, leptospira, malaria, typhoid, and amoebic liver abscess. Another one which affects the liver is rickettsia, which I have not covered in this talk because I think these are much more larger conditions which we see. And liver dysfunction, typically the onset would be in days and will last up to few weeks in most of these conditions. And liver getting affected in any of these may be an indicator of severity, can portend their survival, and may indicate to you that there may be a potential bleeding risk in all these patients. And liver dysfunction can happen due to liver primarily being affected by the organisms or by an immune mechanisms or by hemolysis. And the common liver abnormalities is raised transaminases, increase in bilirubin, and increase in the LDH. And the typical pathological feature, if you remember this figure, it causes necrosis, it causes degeneration, it causes some body deposition, acidophilic or pigment deposition, and invariably all tropical infections have inflammation of the portal tracts and cholestasis, and this is a Kupffer cell hyperplasia. So thank you very much. I'll end this with this quote: "Is life worth living? It all depends on the liver." And you can visit my website to rehear this lecture if you need to gain clarity. And for all the exam goers, if you want to refresh your memory, you can re-listen to this talk. Thank you very much.